Hello, I'm going to make a presentation on ulcerative colitis. Generally, such presentations are made in conjunction with overall inflammatory bowel disease. But because ulcerative colitis has a dominant socio-economic and health impact, I'd like to describe the management of ulcerative colitis first. So, what is ulcerative colitis? As is described by NICE in 2019 and reviewed by them and by the chronic knowledge summaries in 2020. So the description of ulcerative colitis would be a chronic relapsing, remitting, non-infectious inflammatory large bowel disease, which has a significant impact on patients, including adults and children, with colonic, abdominal, and extra-intestinal manifestations, affecting the lifestyle, work, and sports for adults, and affecting the growth and development and schooling of children. So, what exactly is the pathology? It's a disease of the mucosal lining of colon. It is a diffuse inflammation. It's a continuous inflammation in one area or one region with no gaps or breaks in the middle. It's a superficial inflammation of lamina propria of the large bowel. It affects often the rectal mucosa, but involves a variable length of its proximal colon. It could be pancolitis when all parts of the colon are affected. It is supposed to produce its pathology in susceptible people who are susceptible due to immune-mediated or genetic conditions triggered by environmental factors, as well as by the noxious effect of the bowel bacterial flora. The evidence of the pathology comes in from target and random biopsies of sigmoidoscopies and colonoscopies, when one can diagnose on the basis of histology, spread of involvement in terms of disease extent, and how the severity affects the patient's life. So all of these aspects are important in categorizing who has ulcerative colitis and at what stage. In general, the epithelium or the mucosa would be characterized by inflammatory progression, such as erythema, granularity, friability, exudates, and then ulcerations and possibly perforation. Children have more of chronic colitis features without suffering any symptoms. So histology is not the main criterion in children, but behavior and other aspects. So on endoscopy, you'd see striate capillaries through the mucosa into the lumen, and you would see intact areas without congestions, perforation. One stage further would show erythema, which would be in patches or continuous, and then this is followed by granule formations, and you could see granules in various parts here. And of course, if you touch the mucosa via the colonoscope through a suction apparatus, then it would bleed due to its friability. And so friability, granularity, and then pus formation, ulcer formation, which is breach of epithelium, and of course, swelling in general would be the colonoscopic findings. And in terms of histology, one can see that the normal colon has compact barrier epithelial cells, which in a deeper plane go down to produce recess like this called crypts in various places. And these are outlined and these are lined by goblet cells producing mucus, mucin and other important substances. As the normal transits into ulcerative colitis, you would see broadening of the cells with gaps here and there between the cells, and that the crypts become unusually distorted. And as you can see, there is no continuity into the lumen, and there is absence of goblet cells. And then there would be fibrosis and thickening and sometimes pocketing of pus. So therefore, histologically, one can diagnose various types of colitis that way. So the classification would include endoscopic or imaging-based extent. So a patient could be suffering from ulcerative proctitis in the rectum, and this is more common to see in adults, and all of the colon, which is more common to see in children. In between, there would be left-sided colitis limited to rectum to splenic flexure, extensive colitis when it may involve all of the areas of the colon. And I'd like to emphasize that some of the features behaviorally and clinically are similar in all inflammatory bowel diseases such as Crohn's colitis and ulcerative colitis, and the features can overlap, and it will be difficult to diagnose one from the other. So what is the prevalence in the world of ulcerative colitis? This is unknown because the diagnostic criteria differs from one country to another. So in the UK, the criteria revolves around endoscopic biopsy, classification of area involved, such as colon, transverse colon, rectal area, and also on the basis of patient suffering using a tool. However, other countries have their own methods, and usually internationally, it's the histological classification which is described as diagnostic of ulcerative colitis. The peak incidence was reported by the Office of the National Statistics as 85% people who suffer are under the age of 60 years, and the peak band is 40 to 60. In the context of Europe, Scandinavia, which comprises Denmark, Norway, and Sweden, has the highest incidence, followed by UK, and this was measured in 2013. So there are several complications of ulcerative colitis. I would enumerate in terms of how we see them rather than how severe these are. Psychosocial impact is considerable in the adults who go to work but want to make sure that they are near toilets, and children who are limited in terms of their sport and other physical activities, and men are unable to enjoy leisure activities, going to the shopping mall or parks or gardens because they want to see first where the toilet is. The other complication of importance is toxic megacolon. Remembering that ulcerative colitis is a non-obstructive disease, so there is easy flow forward and backwards. There is no fibrosing stricture, there is no mass which is causing obstruction, and yet the affected colon has swollen and balloons out. And it does produce significant abdominal and systemic symptoms, sometimes necessitating a colectomy. Infections, hypokalemia, hypomagnesemia are the consequences, and often one experiences a flare-up or relapse of ulcerative colitis due to bowel preparations which are used for colonoscopy. You can see the toxic megacolon on a plain X-ray of the abdomen. You could supplement this with an ultrasound scan to measure the thickness of the abdominal wall. And so, continuing with the complications, sometimes the inflammatory spectrum is extreme at one part of the affected colon, so much so that there is luminal obstruction, but it is usually not total, and wind and fluid can pass through usually, but it does occasionally, or rather rarely, cause obstruction. It causes perforation more often than obstruction, and this occurs with total colitis, pancolitis, and when investigations are undertaken, or when colectomy, which should have been done timely, has been delayed, leading to perforation and serious complications. Intermittent relapse and remissions can leave behind chronic inflammatory features in the long term, producing intestinal strictures. But remembering that intestinal strictures seen on colonoscopy lead one to first exclude cancer of the colon. From time to time, the contiguous or adjacent organs in contact with the acutely inflamed colon will lead to erosion of barriers, and therefore there would be fistula. And this could be to small intestine, bladder, vagina, or abdominal wall or perianal skin. There would be various forms of anemia produced. If it is due to blood loss, it's iron deficiency. If it is nutritional, it could be not microscopic or hypochromic, but other nutritional anemia. Because of long-standing effects, there would be malnutrition, affected growth and development in children. There would be consequences from losses of fluid. And then again, in children, 10% of the children with ulcerative colitis have growth failure. Whether the ulcerative colitis is precancerous was assessed on the basis of a large meta-analysis of 8 European population-based cohort studies. The results were confusing, and consistently the results showed that the incidence of cancer increases with the age of ulcerative colitis. That means if the ulcerative colitis has been present in a patient for 20 years, then the incidence of cancer developing side by side is higher. Overall, it is calculated that an incidental colorectal cancer can occur 2.4 times more often in patients suffering from ulcerative colitis. There is a term called pouchitis, and that means that when ulcerative colitis is significantly severe, removing of the colon becomes necessary. And then when it does, then some sort of a storage surgery can be undertaken with ileal loop acting as a reservoir. And if such a loop or a pouch is created, then from time to time, the pouch itself becomes colonized by bacteria, gram-negative type, which would cause infection. And now, for some reason, it is called pouchitis. And this is amenable to antibiotics of sort of in respect of gram-negative bacteria. The extra-intestinal manifestations occur in about 30% of the patients, and these might precede the development of colonic symptoms and signs. So there would be major joint non-weight-bearing articular arthritis, such as finger, ankles, knees, hips, wrists, elbows, and shoulders. But as opposed to rheumatoid arthritis, these have asymmetric involvement. They are acute in onset, and they resolve on their own without leaving any permanent joint damage. The manifestations could include those parts of the bone where tendons are attached, producing enthesitis, or all of the layers of tendon, such as tendo-Achilles or quadriceps tendon, could be affected, called tenosynovitis, or the whole digit being affected, called dactylitis. Patient can suffer from erythema nodosum, which is not necessarily raised above the surface, and it's more prominent in the extensor aspect of the legs and the arm. They could be mouth ulcers, they could be eye disorders, and one can see erythema nodosum on the anterior or extensor aspect of legs, and these patches are discontinuous and localized. It can also produce or be associated with pyoderma gangrenosum, and in this patient, a large chunk of S-scar has already been excised, and the area with pus and chronic inflammatory tissue refuses to heal. So this would probably require a flap graft, vascularized graft transfer when the patient is infection-free. Bone disease and eye diseases are also common. And in terms of bone disease, reduced mineral density often occurs as a result of treatment rather than of the effect of colitis, called osteopenia. And when it becomes advanced, it causes a problem with the matrix, and therefore whole bone becomes weakened with osteoporosis. And this happens in 30% of the cases in long-standing ulcerative colitis. There could be vitamin D and calcium deficiency leading to matrix abnormalities called osteomalacia. Ulcerative colitis is also related with venous thromboembolism, and the cause is alteration of plasma protein, viscosity of the blood, and also other features of immobility. So this is episcleritis, with the conjunctiva being normal, the eyelids being normal. So what would be the risk factors in producing ulcerative colitis? Positive family history. For some reason, patients who have had appendicectomy in the past are protected, and the incidence of ulcerative colitis reduces. For some reason, smoking is protective against ulcerative colitis, not so with Crohn's disease, and smoking also improves the chances of improvement from venous thromboembolism. But smoking in the long term, or with ex-smokers, there is 70% greater risk of developing advanced disease, which is more refractory to treatment. So smoking should not be encouraged. So what would be the prognosis? It's a lifelong condition characterized by relapse and remission, and all-cause mortality is slightly greater at the onset of the disease. And there are variable results mentioned. But what is most relevant as a result of these studies is, after 10 years of suffering from ulcerative colitis, the colectomy rate is 9.8%. The British Society of Gastroenterology states that lifetime risks of surgery is 20 to 30% in people with advanced ulcerative colitis. How does one diagnose ulcerative colitis? This is on the basis of symptoms. It may occur insidiously, but often it causes bloody diarrhea for more than 6 weeks. But if there is first-time rectal bleeding, malignancy should not be ignored. There is fecal urgency, which means that the anal sphincter can be volitionally inhibited and controlled despite the urge to open the bowels. But when the urgency becomes greater, there would be incontinence, but never onchoparesis. Tenesmus literally means that there would be desire to open the bowels when the bowel is empty. There are non-specific symptoms similar to chronic fatigue syndrome, weight loss, faltering growth, and non-specific symptoms. In terms of signs, there may be no physical signs in early cases. There'd be features of anemia, features of immune deficiency characterized by opportunistic infections, abdominal distension, malnutrition, or extraintestinal signs. So how does one investigate it in the NHS? Initially, full blood count should be done, and remembering that raised platelets are also inflammatory response, and features of anemia noted. Ferritin for iron, B12, folate, vitamin B12 levels, urea and electrolytes, C-reactive protein and erythrocyte sedimentation rate, LFTs measuring albumin, globulin, abnormal proteins, amylase, and tests for sclerosing cholangitis, which is mainly ultrasound scan of the liver and the biliary tree. Hyperthyroidism should be excluded by measuring free T4 and TSH. Celiac serology needs to be done because it can coexist. Microscopy of stool should be done not just for identifying the bacteria concerned, but also to exclude Clostridium difficile toxin, which is a potent trigger for flaring up ulcerative colitis. Fecal calprotectin is also done, which is estimate of this protectin in the white cell of the stools. Amylase for pancreatitis, tests for inflammatory arthritis such as rheumatoid factor, anti-CCP, and also CRP. The abdominal ultrasound scan is done to look for strictures, wall thickness, megacolon, or fistula. Of course, the hallmark would be colonoscopy, biopsy, and so on. So what would be the differential diagnosis? Crohn's, infective colitis, pseudomembranous non-infective colitis, microscopic colitis, and this aspect is important because it can produce watery diarrhea, and it is associated with some medications such as PPI, aspirin, sertraline, and anti-acid medications such as ranitidine and statin. Ischemic colitis would usually produce sudden onset of abdominal pain, which would be disproportionate to the clinical findings of acute abdomen. And it's associated with eating or when colonic perfusion is impaired, such as with mesenteric artery emboli. Diverticulitis, which is inflammation of the pre-existing diverticulum. Celiac disease, IBS, anal fissure, malignancy, endometriosis, and laxative misuse. Amongst this group, laxative misuse is common. People suffer from constipation and are perpetually on osmotic laxatives such as lactulose and Movicol without drinking much water, and eventually this causes dependence, and then even with use, it does result in diarrhea or inflammation. So how does one manage the flared up situation or when the person is in a state that hospital admission should be necessary? They would deal with resuscitation, blood studies as we described, ECG, urine and stool. They will do cardiorespiratory support and pain relief, and we'll talk about what to avoid. When it is safe, colonoscopy, staging of ulcerative colitis by way of patient severity of symptoms and also classification to differentiate between Crohn's and ulcerative colitis on the basis of histology when it is convenient. and safe for the patient. A relatively non-invasive investigation would be MRE, and this enterography is something which is done often in children in sedation, or when endoscopy is non-diagnostic, and when there is urgency of situation precluding invasive investigations. So once the ulcerative colitis has been diagnosed and the patient returned to the community, what does one do in the primary care? So you assess the impact on daily functioning, assess anxiety and depression. You produce written advice and signposting to various places such as Crohn's and Colitis UK, Crohn's in Childhood Research Association, British Association of Gastroenterologists. They have email system, online information, and they also send written information about management. One should assess about osteoporosis, particularly developing as a result of treatment, and that there is continuity of gastrointestinal specialist following up, either directly or through the colorectal nurse specialist. So additionally, one would need to continue with the colorectal cancer surveillance, which is done in the UK on the basis of fecal occult blood of every adult male and female who are over the age of 70, and therefore must submit a stool specimen in the Royal Mail approved safe bag and bottle, and that if occult blood is found, then the system would arrange for a colonoscopy. One would need to monitor declining ferritin or blood parameters. It's possible that colorectal surgeon may be necessary for advice. When ileostomy is envisaged, a stoma nurse would advise, and so would a dietitian. Patients should be protected against seasonal infections of a viral nature by being given non-live flu vaccine and pneumococcal vaccine. So how does the treatment of ulcerative colitis actually take place from a pharmacological point of view? The aminosalicylates are sulfonamide type agents with an active principle, which is aminosalicylate, and this has a calming effect on the inflammatory nature of ulcerative colitis, and it usually is given orally. But in not so bad diseases, topical treatment is also given, but this shouldn't be given to someone who has got aspirin allergy or allergy to sulfonamide. Corticoid monotherapy is usually time limited, so it is done to bridge the gap between treatment or to produce immediate benefit, to be followed by aminosalicylate treatment. Corticosteroid dependency may occur. If corticosteroid is given for more than a month, there would be implications of steroid in terms of blood pressure, blood glucose metabolism, and also osteoporosis. Generally, corticosteroid is usually given topically as proctoform or steroid enema if the lesion is towards the splenic flexure or more proximal to that. Calcineurin inhibitors such as tacrolimus and cyclosporin can be given orally, but obviously cyclosporin would be given intravenously. And this is given for 2 to 4 weeks to achieve a remission followed by shifting over, if possible, to the aminosalicylative if the patient tolerates it. Immunosuppressive drugs such as thiopurine, such as azathioprine, mercaptopurine, and cyclosporine, if patient is intolerant to others, can be given as well. These are the realm of biologics, and anti-tissue necrosis factor alpha monoclonal antibodies have been in use not as monotherapy, but as a second-line agent, and in rare circumstances where a person is completely intolerant to the first-line disease-modifying medications, then infusions or subcutaneous administrations of these agents can be given. Popular amongst these is infliximab intravenously and Humira subcutaneously now. They are also effective in maintaining remission. So once having achieved remission, periodic administration of these will ensure continuing remission. As an alternative, when drugs are not tolerated well, then enteral, parenteral, and oral nutrition of avoiding certain things, increasing certain things under the advice of the gastrointestinal inflammatory bowel disease dietitian would be very helpful. If someone presents with an acute flare-up, either that person should be admitted with having bloods taken and stool collected and other factors also measured. And if acute admission is not warranted, then urgent colorectal specialist, surgeon, or gastroenterologist with expertise in inflammatory bowel disease should be approached. Patients should not be treated with NSAID like ibuprofen, naproxen, Voltaren, because it would exacerbate megacolon. So there's some helpful advice. When such a patient has diarrhea, do not prescribe loperamide, that is Imodium, or Buscopan. You need to consider excluding gastroenteritis or a flare-up of ulcerative colitis. And similarly, one should not prescribe irritant purgatives because that would perforate a megacolon. Bulk-forming laxatives such as Isfagula husk, which was popularized by Poalicina, also called Avicenna, many hundreds of years ago. Methyl cellulose causing bulk, or esterculia, which is soluble but condenses into a gel in the bowel. So for abdominal pains, avoid opioid medications, NSAID, and also one should manage the inflammation and distension. So for non-specific symptoms such as fatigue, sleep disturbances, stress and anxiety, one should offer counseling, therapy, yoga, building up exercises in line with the exercises suggested for chronic fatigue syndrome. Parameters of anemia should be checked and corrected. And if there's an oral problem, to be referring to the oral specialist. Sometimes advice is sought when a woman of a fertile age suffers from ulcerative colitis and needs contraception. So there are various kinds of advices, and there would be increased risks of thromboembolism with some choice of contraceptives. United Kingdom medical eligibility criteria, which has replaced the WHO MEC criteria, means that advice should be obtained with an interactive discussion between gastrointestinal and obstetric experts. If the treatment is with methotrexate-like substances, these should be stopped for 3 months. And if anti-TNF, then it for 6 months before contraception should be provided. Similarly, when women have had pelvic surgery, surgery for adhesions, then, and if men have had treatment with biologics and some of the conventional medications, then there would be erectile dysfunction, sluggish movements of these sperms, and in women there would be problems of implantation of pregnancy, and therefore expert advice should be sought for these. This is the best way of assessing patient suffering, and this is available on the internet. So you could test patient suffering by way of stool frequency, rectal bleeding, findings on sigmoidoscopy or colonoscopy, and physician's global assessment. And so you could continue to measure these points, and then you eventually collect the data, adding on with the endoscopic index and add points to that as well. So these are points that one accumulates. And in the end, you interpret at what stage of severity the patient is currently to start your overall management. I hope that this was reasonably clear, and I hope that you will also find time to listen to the next presentation, which would include Crohn's disease, inflammatory colitis, and also granulomatous colitis with a description of IBS. Thank you for listening and watching.